I'm going to introduce Dr. Phil Patty. Everyone knows who he is. He's my partner with Vascular Health Partners. Phil's through an upstate resident, did his medical school residency, fellowship in vascular surgery, works at Albany Med for many years, and now Phil and I practice at Glens Falls Hospital in North Country. Phil's going to talk about DVT, what causes it, and why, who's at risk, and let's get started. Thanks, Phil.
Well, thank you very much for all of you coming out tonight. Once again, it's a pleasure to be here, and I always enjoy when Manny says kind words about me. So the topic I was charged with is DVT PE, who is at risk and why, and my challenge was to kind of hit the high points on this, give you some basic understanding, but not bore you with the details, and keep it somewhat relevant. So these are my disclosures. I have no conflicts of interest with regards to this talk. First question is, you look at several people we see in media and stuff like that, papers, movies. What do these people have in common? Hillary Clinton, Regis, Dick Cheney, Zsa Zsa Gabor, Richard Nixon, Serena Williams, Nick Cannon, David Bloom, James Stewart, Heavy D, Teddy Roosevelt, and Frida Kahlo. So we are talking about venous thromboembolic episodes, so it's true. They all have this in common. Hillary Clinton was diagnosed with a transverse sinus venous thrombosis. Dick Cheney, Zsa Zsa Gabor, Regis, Richard Nixon all had lower extremity DVTs. Serena Williams, Nick Cannon had lower extremity DVTs that were complicated by the development of pulmonary emboli. David Bloom, James Stewart, the actor Heavy D, Teddy Roosevelt, Frida Kahlo, all had lower extremity DVTs and subsequently succumbed to fatal pulmonary embolus. So there's many people out there that have these problems. You may not realize they had it. And we'll revisit this at the end of the talk and talk about who's at risk and why and see how it applied to these particular individuals. But these are the facts. The incidence is about 900,000 new cases per year in the US. That's about 1 in 1,000 adults per year. And this incidence increases with age. It's very minimal below the age of 35, but as you get above 40, it increments exponentially up into the 80s. It's responsible for about 60 to 100,000 deaths per year in the US. And this is some data back in 2010. It's probably more so now. And we're hoping it's on the peak and it's trending downwards with the new therapies that are available. And it's really the most common preventable cause of hospital death, as Manny had alluded to. What are the consequences? Well, people don't really talk much about venous disease, but there's very significant consequences to DVT. Pulmonary emboli is probably the worst. And in patients that have symptomatic deep vein thrombosis, it's estimated that about 50 to 80% of them, if you examine them really closely with duplex studies or venograms, will have pulmonary emboli that just either go unnoticed or become severely symptomatic. In hospital patients, it's about a 26% incidence. Patients with symptomatic DVTs and subsequent pulmonary emboli, and 9% of these patients have fatality associated with this. Recurrent venous thrombosis, so patients get a one-time DVT and get it subsequently, the incidence is over a third of patients within 10 years. So if you have a DVT once, you're still at risk, and it depends on the factors which cause the problem, which we'll get into. Pulmonary hypertension, a very dreaded consequence, very debilitating, is complicated in about 4% of patients with pulmonary emboli. So these patients not only have the acute problem, if they don't succumb to it, can have long-term sequelae. And some of this may be ameliorated with early treatments that we're going to be talking about later. Post-phlebitic or post-thrombotic syndrome occurs in about 5% of the population and about 29 or 30% to 80% of patients with low extremity DVTs. Significant problem, long-term morbidity with ulcers, swelling, and pain that can plague patients for the rest of their lives. The pathophysiology, as Manny mentioned, really is attributed to Virchow. The interesting thing is Virchow really didn't know whether these were associated with DVT. He found 2 of them that he thought might be a consequence of it: abnormalities of blood flow stasis, abnormalities of the blood itself, hypercoagulability, and really the third one that's attributed to him after he passed away, vascular injury, was found by a Dr. Cruvelier at a different time in France. And this vascular injury is really endothelial damage and dysfunction. The key thing is that this is usually multifactorial. As Dr. Maida said, that basically there's at least 2 factors that are involved in any one patient. One problem isn't likely to give it. If you haven't found the second or third factor, it's because we haven't looked hard enough or didn't have tests that could reveal that. The facts also are that the incidence increases with age. The age where it starts peaking is age 45, and it increments up to age 80 and beyond. The death within 1 month is significant. DVT, about 6% of patients succumb. PE, about 10%. And what's interesting is the DVT, you'd say, well, you know, the chance of dying from DVT is pretty close to PE, but that's probably because these patients are very sick, have significant morbidities, and many of the DVT patients that die had unrecognized pulmonary emboli. There are significant ethnic differences in the United States. African American, twice as much as the white population, and the white population alone occurs for more than twice that of Hispanic and Asians combined in the US. So depending on where you are, where you're from, what your ethnicity is, can imply directly what your risk might be from DVT. So this was a study looking at DVT triggers, things that might trigger the onset of a DVT. And this is from Lancet, published back in 1999. The significant trigger is hospitalization. Many different factors involved with that. Cancer, close to 50%. Surgery, 42%. Significant trauma leads to about 6% incidence. What's interesting is the triggers are present in over the 50% of patients that have DVTs. So one of these 4 risk factors is very significant in these patients, and we need to pay attention to these patients. And that's probably the genesis of why prophylaxis for this problem means so much. 65% of the 50% that had triggers had multiple triggers. Again, it points out to multifactorial causes for DVTs and PEs in these populations. So looking at the populations at risk, we talked about stasis, hypercoagulability, endothelial damage, and things like that. The population at risk for stasis, the one we know about is prolonged travel. People that get on long plane rides, maybe aren't getting up enough to walk around. There is a significant incidence, about 10 to 12%, with travel that's beyond 11 hours without moving around, of developing DVTs. Patients that are immobilized for a prolonged period of time, patients that have strokes, spinal cord injuries, maybe paralyzed that are not getting around much, significant incidence, close to 50%. Major surgeries, orthopedics, total knee greater than total hip arthroplasties, general surgery, especially bowel surgery, significant incidence. And this is where stasis comes into play. Populations at risk from endothelial injury, direct trauma, people that have massive trauma, vessel injuries, direct blood vessel injuries, venous injuries, vena cava injuries, vessel injury from foreign bodies, indwelling central lines, PICC lines that have been in place for periods of time, ports from chemotherapy, anatomic anomalies, such as Paget-Schroeder disease or axial subclavian DVTs, repetitive injuries, all play a part in endothelial damage. Patients at risk from hypercoagulability, this is the real black box. You know, there's many different causes. Hyperviscosity, people that have abnormal red cells, they've got very high hematocrits. Patients that are dehydrated are at risk for DVTs. Inherited mutations and deficiencies, people that have family histories of such problems. In patients that have first-time DVTs where you can't find a reason, travel or things like that, maybe major injuries, often many of them will have a hypercoagulable state that's inherited, and if you probe deep enough on history, you'll find that some relative, some first-degree relative, father, mother, sister, brother, had a similar problem in their past. Oral contraceptive use associated with 2 to 4 times risk. Replacement therapy the same for patients that are in postmenopausal years. Cancer, 4-fold increased risk, and 20% of all patients that have a first-time DVT are subsequently found to have cancer. Pregnancy, 6 to 10-fold risk. 30 to 50% of them have another problem. Again, multifactorial etiology, coagulation defects are present in these patients as well. Cigarette smoking as well, and atherosclerosis. Looking at stasis, and extrinsic vein compression, looking at one particular example, Mayturner Syndrome was described back in the 1950s, and this is patients that have the misfortune to have a left iliac vein that's compressed by a right iliac artery. And it tends to affect young, middle-aged women, typically was noticed after pregnancy. We note that the iliofemoral DVT rate is 5 times greater in the left than the right. This is actually something that Virchow found back in the 1800s. The treatment, what it points to, is that we really need to take account of anatomic defects causing DVTs, especially in patients that have long-term sequelae of DVTs like swelling, ulcers. We as providers have to look for those particular causes. Endothelial injury. Now, Padgett Schroeder has been talked about. Paige very nicely articulated her own personal experience about this. Most people think it's due to the anatomic compression. It does play a role. You can see in the upper picture, the vein is pretty much squished by in the narrow space between the first rib, the clavicle, and the musculature behind. It's related to repetitive strenuous activity, but if we look at the microscopic level, there's repetitive venous endothelial injury and venous stricturing and thrombosis that occurs. So the actual anatomic defects don't occur without endothelial damage. Again, 2 of those factors in Virchows Triad. Inherited acquired states, hypercoagulability. The most common one is the factor V Leiden mutation. 20 to 50% of first-time DVTs where you can't find a cause, like travel or immobilization from trauma, have this factor. So what we have to pay attention to is to look deep enough to find out if there's a family history. Prothrombin gene mutations, 10% on the average are all first-time DVTs. Protein C and S abnormalities, deficiencies, 5 to 7%. Antithrombin deficiencies, even pregnancy, complicates 7% of pregnancies and up to 23% of postpartum females. Looking at cancer patients with hypercoagulability is what's invoked. 4-fold increased risk, as I mentioned. Idiopathic DVTs, those ones where we can't find the cause, 12 to 17% risk of occult malignancy. And this is interesting. Within 6 to 12 months after diagnosis of a DVT, malignancy is 2 to 5 times that of the age-matched population. Anybody watch 60 Minutes this weekend? So there was a show on about these medical carts that were going around, how patients are lost in Obamacare, the ones that are too poor to be included and not rich enough to be able to afford their own medical care. They talked about a lady that had a DVT, and she couldn't get treatment. So the people Good Samaritans that had found this lady and treated her, and then, she got better. She didn't have much problems. She was maintaining anticoagulation. She got appropriate treatment from these Good Samaritans. Now, the sad piece of the whole problem is when they talked about how she's doing nowadays, they said that 8 months after this show was recorded, that she developed a fatal pulmonary embolus. So they found out that she had lung cancer that was the cause of this. So you have to, first-time DVTs where you can't find an explanation, look pretty hard for malignancy, not just at the time, but within a year after the diagnosis is made. 90% of patients have abnormal coagulation parameters, factor deficiencies, abnormalities, thrombocytosis, and the treatment of cancer itself, even with surgery, has a 7.5-fold increased risk of DVT associated with it. Risk of recurrent DVT, greater than 30% at 10 years. It's usually the same type of event. So a patient gets a DVT within 10 years, probably going to get another DVT. PE is the same way. Most of the consequence of this is from inadequate treatment. And in patients that don't get appropriate treatment for at least 3 months, there's a 47% recurrence versus 5%. So the real question is, was the duration of treatment adequate? Did they have a hematologic evaluation? Did we look hard enough to find out what the cause of this problem was? So this goes to the rationale for DVT prophylaxis. My mother, when I was growing up, used to say a spew of things like, spare the rod, spoil the child, stitch in time saves 9. Well, the one thing that she told me that stuck in my mind always was a little quote from Benjamin Franklin that said that an ounce of prevention is worth a pound of cure, and there is no medical problem this applies more to than DVT and PE. The incidence of DVT in ICU patients in this study from 2005 was 10 to 18% in patients that were appropriately prophylaxed versus 25 to 32% with no prophylaxis. So take your appropriately patients at risk and make sure they're on a proper prophylaxis. Estimated 25% of all DVTs occurring in hospital may be avoided if appropriate prophylaxis was uniformly utilized. So going back to our celebrities with venous thromboembolus, Hillary Clinton, why did she get this transverse sinus venous thrombosis? Well, there were two problems. She traveled quite a bit at that time as Secretary of State, and the second thing is she had a minor head trauma. So the combination of those things, again, multifactorial. Dick Cheney has significant atherosclerosis linked as a risk factor. He was overweight, and he was traveling quite a bit. Zsa Gabor had a massive stroke, was in a wheelchair, developed a DVT pulmonary embolus. Regis Philbin, traveling quite a bit. Richard Nixon, multiple DVTs, recurrent DVT, and traveling while he was in China was when the first one happened. All low extremity DVTs. Serena Williams and Nick Cannon, both African American, highest incidence ethnicity-wise in the United States. Serena Williams had a minor trauma on her foot. She was immobilized for a period of time, developed DVT. Nick Cannon, traveling quite a bit. He was dehydrated at the time, had a minor flu incident. Again, hyperviscosity, lower extremity DVT and PE. David Bloom traveled quite a bit. His wife actually talked and gave at one of our previous roundtables and told very poignantly about the human side of this all. David traveled quite a bit. He was a reporter, correspondent, DVT, massive fatal PE. Jimmy Stewart, very old, age over 80, was debilitated, not very active at the end of his life. Two risk factors right there. Heavy D was a rapper, African American, obese, two major risk factors. Teddy Roosevelt, obese, atherosclerosis, and old. Frida Kahlo, famous artist from South America, was born post-polio patient, had a significant low extremity injury when she was in her teens, and progressively debilitated over her life, developed DVT and fatal PE. So if we go back, we can look at the risk factors and really see how everybody can be explained from what little we know nowadays about these risk factors and how they interact with each other. Take-home message, identify high-risk populations. If you can, as a provider, modify the risk and lifestyle. Give appropriate adequate prophylaxis for those patients at risk, adequate medical treatment available, and appropriate early intervention if there's expertise available to treat these patients. Thank you for your attention.